In this section, we're going to dive into immunodeficiency diseases. Immunodeficiency diseases. And there's two large categories. We've got primary, which are congenital, meaning you're born with them. And then we have secondary, which are referred to as acquired, meaning you've picked it up in the environment. Right? It was transferred to you. So with primary or congenital, we're going to get into a really big flow chart that looks dramatically scary on the slide. And I'm going to try to break it down succinctly like we always do. So we're going to cut this up into different pieces. But now you have this background of the immune system. You understand generally, not in great detail. I mean, a lot of specifics, but it's not like you're immunology specialists. And again, with this topic of immunology, we've spent 2 weeks, right, in immunology, adaptive. We had a week before the exam, then we took the exam, we had another week after, right? And there are entire semester-long courses on immunology. So again, we're just touching the surface of immunology. But what you do know so far is you know that the bone marrow is an important piece of tissue. And in the bone marrow, you've got these pluripotent stem cells. And these pluripotent stem cells can differentiate into pro-B and pro-T cells. It might be a little difficult to see on the center screen, but there's a box right here. It's a little easier to see on the side screens, I think, today. Do you see this box? And that box is indicative of what's happening within the bone marrow. And so you can appreciate that the stem cell from the bone marrow becomes a pro-B cell, and then it actually matures in the bone marrow, like we learned. And then as it leaves, it turns into a B cell that has the ability to produce different types of immunoglobulins. And here are the 5 family of immunoglobulins, right? We've got the IgD, we've got IgM, IgG, IgA, and IgE. Okay, so that's our B cells. If we follow the pluripotent stem cell, originates in the bone marrow, just like we learned, and then it leaves and it goes to what tissue? The thymus. So you could draw like a gnarly looking lobule piece of mass of tissue and call it the thymus, okay, if you want to be artistically accurate. This graph or this picture doesn't show the thymus, but this is where the thymus, right, would be. Actually, it would be in here, right? Actually, no, it'd be this whole thing would be thymus. Pro-T cell, immature T cell, and it gives rise to either a CD8 or a CD4. So we know all this. So at first glance, it looked really scary, but now you know pretty much everything on the screen from an overview. Now, I want to draw your attention to some of these squiggly red lines. All of these squiggly red lines are places where mutations have been discovered. We know that mutations will occur. So let me just explain. If you get a mutation way up top, do you think it's more severe than if you have a mutation way down at the bottom somewhere? Yeah, it's more severe if you have a mutation up top. Okay, so that's the first thing to recognize. Number 2 is you can see that if there's a mutation here, you're not going to make IgA. If there's a mutation here, you won't make IgG, IgA, or IgE. You with me? And the further up you clip, the more downstream problems you have, which is why we said we got to the conclusion of it's more dangerous to have a mutation further up because you actually might kill the entire B pathway or kill the entire T pathway. Okay? So that's an overview of how to look at primary immune deficiencies. These are congenital. These are things that you're born with. Okay? Single gene defects. Something happens, something goes wrong. The mutation occurs, and I'm going to say it because it's pretty bold, but there's a lot of evidence for this. Most mutations are not favorable, biologically speaking. okay? So when you look at this map and you talk about in biology a mutation taking place, most of the time a mutation happens, it is not a favorable mutation. It doesn't mean that the species has some advantage, okay? We like to learn in biology about all these mutations that have occurred over time and how they were favorable to the species. Well, they're in the minority in comparison to the ones that cause all of the problems. If that was the case, most mutations were favorable, hospitals would be out of business. You wouldn't be becoming physicians and nurses because we have more diseases now than ever, right? As the species continues to age, things are getting worse. They're not getting better. Okay. Let's focus now on a B-cell example, then we'll talk about a T-cell example, and then we'll talk about a both example, okay? So I don't plan for you to memorize every single primary immunodeficiency disease. That is asinine, okay? I'll test you on a couple of examples. Fair? But you understand the concept. So when you move on, you start learning about primary or congenital immunodeficiency diseases, you'll know, okay, this is something that happens at the level of the genome, and either the patient doesn't make a certain type of B cell, they don't make a certain type of T cell, or there's been a problem high up and they don't make either. Okay? So, where are we? Okay, we're in this box. This box is blown up. This is the one I want to talk about. This is X-linked agammaglobulinemia, Bruton disease or Bruton disorders. So this is pretty high up. And in these patients, they are going to have what would you expect would be the outcome of their ability to make antibodies? What would you expect? You think they can make antibodies? Not really. So they either have low or most of the time they have absent B cell populations, all B cells. Low or absent plasma cells. So they're not making antibodies at any significant level. What happens with these patients, these Bruton disorders, it's more common in male because it's a X-linked genetic disorder, and so the males get one X and then they get one Y, and if the X is dominant, then they're going to express the disorder. Okay, but it happens in both male and females. But it was discovered in 1952, and it affects the body's ability to fight infections, which makes sense because that's what antibodies do. These patients, these Bruton disorder patients, don't manufacture functional mature B cells. So these pre-B cells never differentiate. They have, however, a normal T cell response. So it's not that the whole system is gone. Okay? So that's our first example. Our second example, that's what this squiggly line was. Our second example is down here because this is the most common primary immunodeficiency disease. This is the most common congenital immunodeficiency disorder. It's an IgA deficiency. So selective IgA deficiency, and these patients wrestle with recurrent infections. They have a problem with recurrent infections. Now, you remember back, IgA is associated with a lot of mucosal membranes. So these patients have a lot of sinus infections, respiratory and GI tract infections. They're 2 to 3 times more common in atopic individuals that they're going to have an IgA deficiency. These individuals, these recurrent infections are in body secretions, and then IgA is found not only in body secretions but also in the blood, right? It circulates in the blood. Okay, but the patients make IgE, they make IgG, they make IgM, they make IgD, and they make all of the T cell response is fully functional. Okay, let's talk about a T cell example. Okay, T cell example. This one's called DeGeorge. The DeGeorge syndrome. This is a problem associated with a lack of a thymus or a partial lack of a thymus. So Angelo DeGeorge was the pediatric endocrinologist in 1968 who described this disease. in patients that had a partial or a complete lack of a thymus, so they don't have functional mature T cells. They're very prone to viral, fungal, and protozoan infections. Some of these patients will go on to get a thymal transplant, and then they'll probably have to be on what type of medication? Cyclosporin. Very good, very good. So you can appreciate here, again, in the thymus, if you have a DiGeorge syndrome mutation, you're not going to make either of the CD4 or the CD8 positive T cells. Okay, and then the last one that I want to introduce as an example, so we had some B-cell examples, we had one T-cell example, and now I'm going to show you the most severe. So the most severe is what's called an ADA deficiency, so adenosine deaminase deficiency. We refer to this as what's known as severe combined immunodeficiency, or SCID. And in this particular case, this is pretty high up. This is in the bone marrow, where you actually make the stem cells, but you never make pro-B and you never make pro-T. Okay? So you don't have mature B cells and you don't have mature T cells. The SCID organism, I talked about in the wound healing lecture some of the research that we did using a SCID mouse. Do you guys remember that? So we had, I'm just trying to pull some of this stuff together. So they manufacture genetic deviants for research purposes. And so there's a mouse strain that has this deficiency, and they don't make functional B cells, and they don't make functional T cells. So if you want to transplant human tissue to do an experiment, like what we did in the wound healing study, you don't have to give cyclosporin because they don't have the ability to reject. They can't use the direct or the indirect pathway. So that's the reason that those models exist for science research. But in the human population, these patients are very susceptible to regular infections. So in kind of like the 1970s, early 1980s, there was a patient, I mean, this is before most of you were around, but you might have heard about a patient by the name of David Vetter. So David Vetter became very popularized in the media because he had this deficiency. He was a little kid, and they referred to him as, it's going to sound horrible, but they referred to him as Bubble Boy because he had to live in a completely contained environment because he had this SCID disorder. He had this ADA deficiency. Okay? Questions on primary immunodeficiency diseases?
So, for this deficiency, you almost don't have an immune system at all.
You pretty much don't. You have the ability for inflammation.
So you do get inflammation.
Yeah, you have macrophages. But yeah, I mean, viruses and bacteria, I mean, your macrophages only do so much.
So if you were to get a cut, you'd have to close it up. It'd be very important to close it up fast.
Yeah. And you would have to probably be on systemic antibiotics and like a local antibiotic treatment. Yeah. Whereas you and I mean, probably many of you, you know, it's like you clean it, right? Like coaches, you say, rub some dirt in it, get back out there, right? Probably most of us, that'd be fine. You could rub some dirt in it, and you know, it might be red for a couple of days, and then it'll be fine, right? You know, nowadays we always put like a Neosporin or some sort of ointment. We clean it out. You know, you splash it with rubbing alcohol or hydrogen peroxide, and you clean it out. But a lot of people don't do that. They just wash it, and they never put anything on it, and it heals just fine. For a SCID patient, they could probably die from that because they could go systemic infection in their bloodstream, because they're not making IgA that circulates in the blood. So as soon as that little bacteria from whatever they cut it on gets into the bloodstream, they have a blood infection. People die from blood infections really quickly. Yeah. So this is a big disorder. This disorder is not a good one. It's hard to see. Okay. Let's talk about secondary. These are acquired. These you can catch from somebody who's contagious. Okay? Secondary immune deficiencies. But they're also acquired, meaning that something causes them. It's not that you're inherently born with it. So, secondary immunodeficiency diseases, the better terminology from catching it or you're infectious is that you acquire it. You pick it up along the way. So here are some examples of a secondary immunodeficiency disorder or disease. Malnutrition, stress, cancer, or in certain cases like iatrogenic side effects, where you're having surgery and they suppress the bone marrow, and now you have a problem with your immune system. Okay? Iatrogenic just means like an inadvertent adverse effect. You didn't mean it to go that way. So like malnutrition, here's an example for malnutrition. So zinc intake, right? If it's compromised, if you don't have enough zinc in your diet, then your ability to manufacture B and T cells can be compromised. Okay, so that's one of the reasons a lot of these like over-the-counter remedies are pushing zinc. There is some science there where zinc as a coenzyme helps with the production of B and T cells. Okay, so if you're not getting enough zinc in your diet, you could be under-stimulating your immune system. Stress, one second. So glucocorticoids are released during stressful times. It never ceases to amaze me during exam week or final exam week, the number of students that become sick, okay, like legitimately ill, probably because of this. We are subjecting you to a secondary immunodeficiency disorder. It's called exams, okay? And stress increases glucocorticoid release, which has been well described in the literature to suppress the immune system. Cancer. Certain types of cancers like Hodgkin and non-Hodgkin lymphomas will deplete lymphocyte numbers. So, and then the last one obviously is infection. There are certain infectious agents, certain infectious viruses that will suppress the immune system. And of course, we're going to talk about one here in just a second. But first, a couple questions. Yeah, I mean, yes, that's what they're going for. I've never seen any clinical data on zinc cough drops being able to, stimulate B and T cell production. I'm not sure that there's enough in there to do anything. I don't know if it's true or not, but that's the marketing angle, yes. Yeah.
So this secondary immune deficiencies, these are curable?
I wouldn't say curable, but in most cases they're treatable. In some cases, like the one that we're going to talk about, it is treatable, and we've done a pretty good job with it, but we haven't cured it yet. I'm going to talk about HIV.
But they're like the example of weird things you pick up from the environment. Say like I go on like a mission trip to like Africa, and I give malnutrition for like 2 months to catch something. Is that going to be with me the rest of my life?
Well, it depends on what you catch. Yeah. Yeah. And a lot of times we don't get to choose. It kind of chooses us, right? Yeah. So the better way to think about the category of secondary is you weren't born with it. So you're exposed to it, and you're subject to it along your life. And some of them, like malnutrition or stress, right? I mean, you could just do some Zen methods and lower your stress level and fix that one, okay? Cancer, a lot of cancers aren't curable, right? And then this infection of human immunodeficiency virus, HIV, is obviously not curable. Well, not yet. I actually think in your lifetime that the medical field, the scientific medical field, is essentially going to come up with ways to truly cure HIV. I think we know so much more about the disease. Now, granted, healthcare is a great field to go into from a job security standpoint, because, like I said earlier, patients are always getting sick. The smarter we get, the more diseases and viruses we discover. So HIV isn't in the news these days. What's in the news these days? The coronavirus, right? I mean, this one's a big deal, right? I mean, the stock market, dropped like 1,900 points as a result of corona, this isn't a finance class, but what is the actual link there? It's like, okay, well, it's kind of crazy how that works. But that's what's in the news these days is coronavirus. We have no handle on coronavirus, okay? But back in the 1980s, I mean, this was the scariest thing on the planet. Absolutely was the scariest thing. So let's talk about this. Is an acquired immunodeficiency syndrome known as AIDS that comes from human immunodeficiency virus, HIV. So some details, bless you, about HIV. It likely arose from a simian immunodeficiency virus and then mutated and began diversifying as early as in the 1930s. It was first found to cross over into humans from primates to humans in 1959 in the Democratic Republic of Congo. Currently today, heterosexual activity is the most common way the virus is transferred. And heterosexual activity, I state that because there's a period of time where a lot of homosexual activity was rampant in certain parts of the world, and that's where a lot of these communities were being infected or transferring the virus around. Now it's actually heterosexual activity. So transmission can be blood, IV drug use, sexual intercourse, maternal fetal transfer. So unfortunately, the virus has been demonstrated to cross the mother-fetus blood barrier, so that the child unfortunately can be born with HIV if the mother has HIV. So just some characteristics of what the virus looks like. So it's an RNA virus, you can see in the middle here, and it's protected by this caspid layer, this P24 caspid layer, this yellow structure. Then that's wrapped with another matrix, which is known as the P17 matrix, and then there's a lipid bilayer that surrounds the outer surface. So it looks pretty robust, but in reality, if it's outside the body, it is very weak. It cannot live outside the body very long whatsoever, okay? And so it looks pretty protected. And here is the HIV virus, and this is a helper T cell in blue. And so I'm going to show you kind of what it does to the helper T cell. And now that you have an understanding of how important the helper T cell is, you'll have an appreciation for why this disease became so problematic, okay? So HIV-1 and HIV-2, there's two different variations or variants of it. So it's a member of the lentivirus family. HIV-1 is the most common of the two types, isolated from patients in the U.S., Europe, and in Central Africa. And HIV-2 is more common in Western Africa. The lipid envelope that we're talking about here, this lipid envelope comes from the host. That's a lipid envelope that comes from the host. So the P24 and the P17 is part of the virus caspid itself, and then it envelops with a host lipid envelope, and that's actually one of the ways that it hides from the body, right? It hides from your immune system, is the outer covering is like a cloak. It's a cloak of your own cell's lipid layer, not the virus, which is really clever if you're kind of nerding out on how HIV hides from everything in that we know about on how to get rid of it. There's a huge mutation rate associated with the virus, and so it's very difficult to stay on top of it. It mutates at a faster rate than even the flu virus. So this is the progression of what's taking place with the pathogenesis of HIV. So we've got here, this is the cytoplasm of a CD4 positive helper T cell. Here's the virus right here. It's got this GP41 and this GP20 is like a docking protein. So the GP20 binds to the CD4, and the P120 binding to the CD4 of the helper T cell, which is down here, it utilizes a receptor known as the CCR5. Okay, so the CCR5 is not shown in this figure, but this is actually pretty important because that CCR5 docking enables for GP120 to bind to the CD4 on the helper T cell. It actually goes through a conformational change, and then it penetrates the membrane, and as it penetrates the membrane, it injects that caspid into the helper T cell, and now the helper T cell is infected with the virus. Okay. Some interesting facts about the CCR5 is there are some individuals now that we've discovered that are actually homozygous mutation, and they are mutants for the CCR5 receptor. They don't express it. And the CCR5 receptor then doesn't enable it being absent. You don't get this interaction, and they actually are immune to contracting HIV, which is pretty crazy. So there is a publication by a high school student, okay, but I want to show it to you. This is the link. This high school student, Julia, I don't know her, I just found her. This is a Nature Education citable journal that talks a little bit more about the CCR5 receptor. I thought you guys would find this interesting if you want to read a little bit more about it. I was impressed that this was from a high school student, okay? But it's actually a pretty good article. So CCR5 receptor mutations, that may be, in fact, where the secret is for some of the new research in the future of how do you actually eliminate the CC5R receptor, or how do you make an antibody against it so that you can actually block it, right? Maybe we can use the immune system to combat it. Okay, so how does this thing progress? And then what happens? And then we're done. Well, you've got the CD4 positive T cells that come into the lymph node. They're exposed to the virus through this process known as viremia. And as they're exposed, they get some replication that takes place. And as they replicate the virus. So they're making other CD4 positive T cells that actually have the virus particle within them. There's a period of time which is called the clinical latency phase, where the virus actually kind of remains dormant and it doesn't replicate. And then at some point in time, it awakens. And we don't know why, what causes it to awake. There's probably, like most immune deficiency diseases, there's probably some trigger point that could be environmental. It could be a significant illness. It could be a lot of stress. It could be all sorts of things that trigger it, just like what we talked about with MS or what we talked about with lupus, systemic lupus. Okay? So the last graph or figure that I want to show you has a couple of things going on, but it explains what happens to the disease over time. So you got time on the x-axis. On this side of the y-axis, y1, you've got helper T cell populations in blue. And then over here on y2, on this side of the y-axis, you have the number of copies of HIV, or what we call viremia. And on graphs, when you've got a little hash mark, that means that it's not to scale. So you can see it goes 0 to 12 weeks, and then it jumps to years. Okay, that's why there's a hash mark here. So what's happening is you get your primary infection in the acute phase, and the number of CD4 positive T cells takes an immediate drop. It slowly builds up, and it stays elevated for some period of time of clinical latency, and eventually it starts to decrease. And when it gets past a certain threshold, you are subject to what we call opportunistic diseases. Simultaneously, the number of copies of the virus, they elevate. And so if someone was to be tested for HIV after an exposure, if they're tested in the first couple of weeks, they may test negative. If they're tested 3 months out or 6 months out, it's more likely that you're going to get a true indicator of whether or not they've contracted the disease. Does that make sense? So when someone has like a needle puncture in the hospital and they're all worried because of an HIV positive patient, and they go get tested the next day and they are negative, it's like, great, but you probably need to come back in, I would say, at least 6 weeks, if not longer, and get tested a couple of more times. Does that make sense? So the number of copies elevates, it settles down, and eventually in this phase, in the crisis phase, it ramps up. So the opportunistic diseases, and I know we went a couple of minutes late, but the last thing I want to say is nobody really dies of AIDS. Okay, they don't die of human immunodeficiency virus, and they don't die of an acquired immunodeficiency syndrome. They die of some other infection that takes over the body, and the patient that now has AIDS, they have an acquired immunodeficiency syndrome, they can't fight it off. So a lot of patients, AIDS patients, end stage will die of like pneumonia or some other infection, a blood infection, and they just can't fight it off. Does that make sense? That's what we're talking about with opportunistic diseases. Okay. Thanks, you guys. Have a great weekend. We've got a whole new topic next week, okay? So we're out of the immune system.